Within each therapeutic regimen, we have a host of targets broken down by their characteristics, simultaneous perception, which means that each eye sees a different right eye and left eye view, wonderful in measuring subjective and objective angle, also important in breaking suppression in patients who have intermittent exotropia. Various flap fusion targets. We've changed both the size and the size of the suppression area. This allows the ability to use a host of targets that can be changed instantaneously by size. In addition, we can change the mode of vergence. Manual, which is controlled by the controller. Auto, where you set up the base in and base out vergence demand, and it goes back and forth between them. Stopping in case a person suppresses the right eye or left eye, you can stop the image. Flashing the target allows us to break down suppression. We can work both horizontal and vertical together or separately. In a patient who has a vertical deviation, it's nice to put the vertical in there and then lock it down, hit the H, and only work with a horizontal deviation. When we're working with auto or manual, the disparation rate can be changed. All of the stereoscopic targets contain retinal disparity to give three-dimensionality to it. This is the ultimate goal of having normal binocular vision. In esotropic patients, you want to bring them from simultaneous perception to flap fusion to stereopsis. We have all the targets necessary for that. Like anything else, different clinicians like different types of targets, different therapists will find their favorite. It's all here. The rotation targets adds versions to vergences. It can be done manually, where the doctor manipulates it. Auto, which is to change vergence as it's doing rotation smoothly, or randomly, so there are random changes. Great way of developing voluntary vergence. You can run it clockwise, you can run it counterclockwise, or you can have it go in both directions. You can change the rotational speed, you can change the intervals. You can do this with flap fusion targets, you can do it with simultaneous perception targets, or you can do this with stereoscopic targets. Whatever your treatment protocol is, we actually have the targets that will be able to be used for it. The multiple choice program is probably the guts of the whole thing. It's what makes it really special. It's what allows us to build up vergence amplitudes using an operant conditioning paradigm so that the patient can progress at the speed that they want. The most powerful one is a random dot stereogram. The nice feature with this is that we can change the size on the fly. You can make it large if the patient's having difficulty, or smaller. We can work horizontally or vertically, base in or base out. With computerization, it's standardized, repeatable, you know what's happening with it, and any technician can do it. Jump ductions. Jump ductions are set up either in step or random. In the step function, one has the ability to either do it with both base out and base in happening at the same time, the preferred method. Or if you have a patient who you only want to work on divergent stability, you can set it base in. Or if you have a patient who you only want to work on convergent stability, you can work it base out. The beauty of this is that you can change from a step or a random, do a base in and base out, to one eye or do both directions, and you can change all of the variables. You can even do a lot of them on the fly when you're in the program. So convenient for use. The diagnostic package allows the ability to measure of various groups of eye function, from phoria to fusional ability to fixation disparity, anisoconia, cyclodeviations, motor fields, fusional amplitudes, saccadics, visual memory, pursuits. One of the chief advantages is that through one menu, you can reach all these different visual functions to test.